we do not have more than enough.
Assalamualaikum. It's great to see everybody. After that introduction, I don't think there's anything much that I need to add. So it's great seeing everybody.
Thank you. Dr. Adnan, so
okay,
sir, because Dr. Adnan is the medical oncologist from Ziauddin joining us. Dr. Shayan is our neuroradiologist from the ATU. Dr. Shumaila Roj is also neuroradiologist joining us from the GPMC. And then we'll start today. We have the first case coming from
Dr. Adnan Jabbar is an MD PhD with Aditya.
Okay.
And Dr. Shah,
I'm a Mutford.
And Dr. Shan Raza is practicing at MD Anderson. Sorry.
Yes, I मैंने बता दिया था, sir. So now we can move on to our first case, and the first case will be coming from Peshawar with our very own Dr. Sarmad Bukhari. And Dr. Sarmad, I'm going to change my slides and then you can take over. Can you see the first slide?
We can see, yes. Go ahead.
Yes, I can.
Sarmad, you can introduce yourself and then you can start.
Assalamu alaikum, everyone. My name is Dr. Sarmad. I'm a neurosurgeon currently working in Peshawar. I did my residency at the Akhwan University Hospital. And I wanted to discuss this case in the Pakistan Neuro-Oncology Tumor Board. So this is a 37-year-old male, right-handed with no known comorbids. He presented not to me, but to another neurosurgeon in January of 2023 with new onset generalized tonic-clonic seizures. And an MRI was done at the time, which showed a right frontal intraaxial lesion. The neurosurgeon who saw him at the time, so this is not the scan from that time. At that time, the lesion was a little smaller. And the neurosurgeon at the time started him on steroids and anti-epileptics and kept him under observation, which is how they generally treat these cases here in Peshawar and in the surrounding areas. So more recently, the attending neurosurgeon who was seeing him repeated the scan after about 6 months, which showed that the lesion had increased in size slightly. So the neurosurgeon referred them to someone else for opinion, and then they came to me for advice, and these are the scans. Essen?
Yeah, let me know when you want me to move, okay?
No, would the neuroradiologist like to comment?
Sure. We have Dr. Shumaila and Dr. Shayan. Dr. Shumaila, would you like to add, please?
Assalamu alaikum, everybody. Yes, I went through the scans. What I found in these scans was that basically we have only the FLAIR images in this case. Just for the beginners, if there are any on the forum, that in all these images, the gray matter is white and the white matter is gray, and CSF is black. So these are basically FLAIR images. We have axial, coronal, and sagittal FLAIR images. And here we can appreciate that there is an area of vasogenic edema in the right frontal lobe, which is crossing through the corpus callosum. There are few areas which are FLAIR hypointense, central FLAIR hypointensities are seen. So this is all I can appreciate on this. I don't have contrast and T2 weighted images. I don't have plain T1 weighted images. So very limited.
Dr. Shan, sorry about that. So I can fill in that information. So the lesion was non-contrast enhancing in all of the parts. And I just, let me just open up the scans real quickly. They're quickly being downloading to my system. Just give me 2 or 3 more minutes.
Sure, no problem. So,
I should have them.
Dr. Shayan, would you like to add something?
Yes, I think as Dr. Shumaila said, we only have limited images over here. So, but we see parasagittal lesion in the right frontal lobe, which is also extending and involving the corpus callosum. The slightly exogenous on sequence, but of the signal intensity is from 3 to 8 degrees, and blood brain barrier, whether there is that or not. So we can really comment on those things.
Okay.
Let's see how
I can't understand. Is the
So
audio
there
clear
was
to everyone?
some distortion in Dr. Shayan's voice, but so Sharma, do you want to show, or we can proceed to based on?
If you just give me just a few more seconds, maybe a minute, the files are being downloaded. Let me see
So,
what I
I
have.
mean,
and
But
what you are
based on
saying,
these images,
yeah,
yes,
what you are saying, we trust you. It was
yeah,
there was no contrast enhancement.
non-contrast enhancing
Let's move forward.
intraxial.
A neoplastic lesion, actually, it appears to be a neoplastic lesion with some vasogenic edema extending through the corpus callosum. Since you said that it is not showing any contrast enhancement or post contrast even, so it's probably some intermediate kind of a lesion, because I will not call it low grade initially, because there is some crossing through the corpus callosum, which probably points to some low to intermediate kind of a lesion. No enhancement points that it is not a very high grade lesion. So this is what my opinion is.
Okay.
Thank you.
So, so you're thinking about kind of a lower grade, maybe, or possibility of high grade. So the recommendations, if we discuss here. So, Sarmad, you said the patient was on steroids, right? So
for a while, but then they were stopped,
okay.
and then he was only on levetiracetam for seizure control, and seizures were well controlled on that. He hasn't had a seizure. He did not have a seizure until he presented to me. So I recommended to the patient that he should undergo a neuronavigation guided craniotomy under general anesthesia. I did not think that an AV craniotomy would be helpful for him. So a craniotomy under general anesthesia and maximum safe resection. I had a conversation with the patient before the surgery. If you go back to the scan, the axial sections, and I discussed with him that on the medial and posterior and inferior aspect, as we approach the corpus callosum, there may be a risk of injuring the ipsilateral ACA, and that might give him deficit of one of the branches of the ACA, and we might have to leave a little bit of tumor at the back there. And he understood, so we went ahead with surgery. And Asan, if you could show us the post-op scans. And again, so I have these. I can pull them up right now. If you want me to share my screen, I can show them all to you.
You want to show now the post-op or the pre-op?
The post-op scans, if you like. They're up on my screen right now. Would you like me to share my screen?
Okay.
आपको time manage करना होगा खाली बस.
Sure, sir.
Yeah.
If you can stop sharing your screen.
So there are already interesting questions coming up. Approach के बारे में, सब के बारे में. So yeah, दिखा दें जल्दी से पहले.
So I'm going to go through the slides as they are on the left. So this is a sagittal T2 weighted sequence. As we go from lateral to medial, make this a little more useful. So on the sagittal sequences, if you see from lateral to medial, as we approach the medial aspect, you can see this hyperintense signal. And if you match it with the preoperative scans, this is, to me, it looks like residual disease. And over here as well, there's this hyperintensity inside the gyri that I was not able to get. But over here,
corpus callosum भी है ना?
So over yes, corpus callosum, yes. It's also in the corpus callosum over here.
आगे चलिए. So basically we have a very good resection with some residual near the cingulate gyrus, in the cingulate gyrus anterior part ACC, and in the corpus callosum, right? With intact
so here
ACAs are intact.
Yes, so I was able to visualize the ACA. So this ACA was a little above my resection margin. So the resection margin is actually here. It's this. This is Surgicel that's kind of floating around in
Right.
the cavity. It all fell down. And I think this, based on the flare sequences as well, if I show you the flare real quickly. Back here, you see this part? This is what looks like residual to me. Dr. Shayan, what do you think?
Yes, I agree. You explained it well. There is recommendations around the
Dr. Shayan, your audio is not clear to
Dr.
me.
Shani,
But
Dr. Shani
she agrees that it's a
with our,
residual.
yeah, she agrees with our assessment. So,
Okay.
so let's move forward now in terms of what is the plan. Do we want to have the radiation oncologist and the medical oncologist give their opinions?
So
Dr. Adnan.
just one more thing about the histopathology. So we sent a frozen section, and based on that, they told us that this was a low-grade glioma based on the frozen section. They made some permanent slides of the a frozen sample as well, but we don't have all the immunohistochemistries available here. We only had GFAP, P53, Ki67, which is less than 1%. GFAP was positive. But one thing that they noted was an abundance of chemistocytic cells. The final histopathology has been sent to the Aga Khan University, but it's still pending because it'll show up in our system. It's still not there as of yesterday.
Okay, so I'll like to ask Dr. Adnan this question. So, looking at this image, low-grade glioma, suspicion of low-grade, and histopathology, it looks like it will come out as low-grade, but final has not come out. So, if there is a residual in this case, what will be your recommendation?
So obviously, if you look at it, once you have it at corpus callosum, this cannot be resected. This patient will need, once we have the final pathology, additional adjuvant therapy. And usually that would include radiation as well as chemotherapy. We typically use temozolomide, but if this is oligo, you also have a choice of TV, which is a little more commonly used, and that is the one that showed us any benefit in terms of giving adjuvant. You can give it either before or after radiation, but I would certainly like to have the histopathology first before making the final recommendation. When you have residual disease, they come into the category of high risk because, as we know, in gliomas, age over 40 and residual disease are considered as high risk. So hence, he fulfills one of those criteria. And I'm sorry, what was his age again?
37. He's 37.
So, I mean, he's under 40, but residual disease certainly. So histopathology is where I will place my money on.
So if it comes out, yes, sir, Dr. Athar.
I mean, so it does look like it's a low grade or on the lower side. It can be, may have some features which may push it to the grade 3. But let's say if it's grade 2, and it probably may end up astrocytic tumor. But let's say even if it was grade 2 oligo, with that residual and the young age, shall we consider CCRT, or shall we consider re-resection?
So, with the corpus callosum, will never be able to give him a prosthotal resection. So, I mean, you will have to end up giving him radiation and chemotherapy.
Yes. Okay, thank you. So that's what will that be conclusion of this tumor board on this case, or is there any other opinion? And Dr. Sarma, do you have any thoughts on that one?
So we discussed this in our own tumor board 2 days ago, and one of the surgeons present was of the opinion that we should go back and take it out. But the oncologists didn't really agree with that. I didn't agree with it because, I mean, we could go back, but there's a very real risk of damaging the ACAs or giving him deficit. And with a deficit, despite having complete resection, we may be reducing his overall survival, if I'm not wrong.
Yeah. And the Dr. Adnan Jabbar bhi jo keh rahe hain, corpus callosum ko involvement garche ke there are some literature that supports invasion into corpus callosum. I mean, not invasion, resection into corpus callosum also, and we have done that as well. But mere khayal mein I will lean more towards CCRT.
With temozolomide.
Yes. Doctor, any other thoughts from, well, we have
Doc-
Dr. Shan Raza, we have
We can
Dr.
ask, yes, Dr. Raza, what are your thoughts?
Yeah, I think in this scenario, there's always a consideration in terms of whether or not re-resection should be done. And of course, that's really dependent on the treating surgeon. But I think when you look at the scans, there may be some debate in terms of whether or not some of the residual disease along the ACA can be resected. I think if you had gone one sulcus back and then followed that straight down to the corpus callosum, you could have gotten some more disease volumetrically, but ultimately there would have been some microscopic invasion into the corpus callosum that you have to make a decision in terms of whether or not you want to resect that or not. I think there are mixed feelings here at MD Anderson in terms of how far to chase out the disease into the corpus callosum. Nonetheless, moving past that, I think I would consider this a high risk patient. It's close enough to 40, presenting with symptoms and clear residual disease, and so for something like this, we would definitely consider chemo radiation therapy, likely with PCV.
Oh, that's interesting.
With
So,
PCV.
yeah, that creates a little bifurcation. Okay, so do you discuss that, Dr. Hassan?
Sure,
PCV
sir.
versus okay.
Yeah.
And
So,
I think in that,
Doctor, you will prefer PCV, right?
So, at least here, our medical oncologists would prefer the PCV, but sorry, I'll stop there.
No, go ahead.
Yeah, I think the original RTOG trial was done based on PCV, and so, essentially there are two camps of medical oncologists here, some that are purists and stick to that trial and offer PCV, and others that would certainly recommend Temodar.
Yeah, so because
what will be Vinay's thoughts on this, Sean? Vinay Pudawali.
I think he would likely use PCV.
You're right. Okay, all right. Adnan, your thoughts, boss?
So PCV is perfectly all right, because if you look at the data, most of the phase 3 studies basically used PCV, and hence that is the recommendations. But if you look at NCCN, there is data coming in where there are trials which are comparing head-to-head PCV versus temozolomide. So until those come out, in Europe, there are many phase 2 trials which have used temozolomide with and without. And there's enough data to use temozolomide as well. The only reason I personally do not use is you get a very deep cytopenia when you use PCP, and sometimes we do not get the drugs, like procarbazine was short, so you get interrupted. Temozolomide is easy to take, doesn't cause that much cytopenia, and hence preference is temozolomide.
And Adnan, correct me if I'm wrong, the difference in price is about fourfold, right, between TMZ and PCV?
Well, not anymore, because we get this generic temozolomide. There is a huge gray market within the generic ones, so you can get them for 3,000 versus 30,000. So yes, PCV is max 10 to 15,000 rupees. It is cheaper. It is a 6-week trial. I mean, 6 weeks interval. One cycle is only 6 weeks. Whereas temozolomide is 4 weeks, 5 days treatment, and that costs around 60,000 rupees. If you get the generic from a good source. So there is a 5 times or at least 4 times cost difference.
But then with PCV, you would need more of frequent follow-ups and blood tests, I assume.
No, not exactly. They'll always be the same. They do come to see us around the same time. So I wouldn't say that much more than that. But if they do get cytopenias, then obviously there's a long wait and there is that kind of involvement. But I mean, we are comfortable using both of them.
Dr. Sarmad, what was your thoughts over there in terms of temozolomide versus PCV?
So our oncologist, before I came here, he would generally treat almost all of his patients with PCV, not temozolomide, and then we had a discussion about it. And I've done one other patient who I asked to be put on temozolomide based on what I thought was what we preferred at Afan. So she did well. She has good disease control now. But now with this discussion that has been done, this tumor board, in our tumor board, we decided to go for CCRT with temozolomide. But now I'm not sure. Maybe
You'll
I
be
should
fine
let
either way.
the.
So,
Okay.
I mean, it's more of the, it seems like it's more of an oncologist's choice and you know, it's easier to manage, I think, temozolomide.
It is.
So,
And patients are happier with.
and there is no strong evidence of one versus the other. But then it's just a very interesting point that Sean raised or Sean mentioned, using PCV in a HIC setting. I mean, you know, you tend to say that PCV is good for LMIC setting because of lower cost. But then I didn't know that MD Anderson was actually preferring PCV for these things. That's very interesting point.
Yeah, I would like to add the Mayo experience.
Noor,
Dr. Noor, welcome.
We would not listen to you, Noor, unless you introduce yourself.
No, Dr. Noor, no.
Oh, can you hear me?
Someone
Sorry.
We
mute
can
her.
hear you.
We can hear you. Dr. Noor, they're just.
Okay, sorry about that. So, well, not for someone who don't know me. I'm Noor. I'm one of a fellow at Mayo Clinic Neuro-Oncology, and first of all, some good resection, and I think there is a bit tumor at the level of corpus callosum, and I would say that we are really very aggressive with this part. I mean, I would say that if you have if you have a patient next time, I think we should try doing the resection, and it's you can definitely not resect the tumor on the opposite side because the tumor is going on the left side of the corpus callosum too. But you could do a little bit more, as Dr. Raza mentioned. But in that case, looking at the residual disease, which would have never been possible to do a complete resection, even if you have taken that small part. And I think my experience is also the same. We use temozolomide here. I've not seen, I mean, I would not say never, but I've not seen patients being given PCV as their first choice for these tumors. Yeah. And also I was wondering that are we doing IDH there nowadays, or it's still not there? I mean, are we doing the IDH mutation?
Yes.
Are we testing?
We are doing IDH, and they are waiting, as Sarmat said, because we don't have the final histopathology.
Okay. Yeah. So yeah, I mean, with the
very
ideation.
interesting. Thank you, Noor, and Sean. You know, these are two top centers, and MD Anderson is the cancer center, and then Mayo is doing this. So that's wonderful that we have these opinions. Any further thoughts, SN?
No, I think so. I think that was a really good and interesting discussion. So, Sarmat, yeah, yes, sir. The question that I could ask you, there was a question about the approach. So maybe if you want to, because I don't see Dr. Riaz, any other neurosurgeon. I'll take
I see the question by Dr. Nikad Ahmed.
Yes.
Can it
So he's asking about the approach.
The transcalaceal interhemispheric, I assume he's talking about. But once the tumor was removed, I could actually see the entire false cerebri. So I could just cut it and just go across. I mean, it doesn't have to be transcallosal. I mean, I could see it right there. But because the ACs were jumbled up at that point, I didn't want to push. And based on the navigation, I was at the end of it, but that is just something you learn with experience, I guess. I thought I was at the very end based on the navigation, but then you have brain shift. And if I had an ultrasound, maybe I would have been a little more.
Yeah, I was going to tell you that ultrasound is really helpful in these cases. Yeah.
So the problem is we only have one ultrasound machine for the whole floor, and it kind of stays in the ICU because they kind of need it.
Well, anyway, if you notice, Sean was saying, and you know, I would like to hear Sean also. So you may not need ultrasound because once you're down there, you just have to look at the anatomy and just follow the cell side. and you can do that. I mean, it is easy said than done, I agree. But then ultrasound is also not, very, very helpful many times when you have blood in there, and it's like a narrow little space and you're trying to push your probe in there. But in terms of approach, I think that's what I would use. Sean, what are your thoughts about approach on that?
Yeah, no, I mean, I agree on that comment in terms of using the sulcal anatomy to follow that down along the posterior edge of the tumor. And then, there's always concerns about the ACAs, but you can always stay subpeel along the ACAs once you find them in the interhemispheric fissure.
Right.
And then certainly echoing the comment regarding ultrasound, I think that's helpful in these cases.
Right.
Okay.
Okay. Next case.
Any questions from the audience? If no, then we move to the next case. I can see Dr. Mazhar. Assalamu alaikum, sir. Sir, what about the Shaukat Khanum? You use PCV temozolomide for these patients?
Actually, because we treat a lot of indigent patients, so we are not able to sort of give temozolomide to all the indigent patients. So we use modified PCV 6 cycles. But a patient who can afford temozolomide, I certainly agree it has least side effects as compared to PCV regarding cytopenia. So, but majority of our patients are on PCV modified. Only patients who can pay for temozolomide, then we give them temozolomide, and the radiation certainly in this case is indicated because there is a residual disease. I won't go again for surgery at this stage, and I would give 54 gray in 30 fractions if he's affording temozolomide. If not, then PCV modified.
They are affording.
Yeah, then I think there is no data that would show superiority of one over the other. So if they are affording temozolomide, just you can start concurrent with chemo with radiation, and then once the radiation is completed, then he can be shifted on to 5 days a week month oral chemotherapy.
Just a quick question. When you say modified, what part is modified? I'm sorry. Maybe
actually
in
modified there isn't much difference, but in modified we just reduce little bit the dose depending on the performance of the patient. That's all. Otherwise, it's the same PCV.
Okay.
Yeah.
Guys,
because most of the patient have poor performance status, and because we have no choice then to give them PCV, and we see that they will not tolerate the full doses, so we just modify a little bit the doses by decreasing the percentage.
Okay, got it. Thank you.
Amazing discussion. I'm so really, this is amazing. Hassan and Sean, what you guys and Sean, thank you for
bringing up PCV in the discussion. Right.
All right.
Okay.
Thank you, everyone.
Yeah. Thank you, Sarmad. And we're looking forward to more cases coming from your center, inshallah. And